Thank you, Rob. Good afternoon, everyone. Again, my name is Johanne Eliacin. I am a research scientist at the Bush Medical Center in Indianapolis and research psychologist at the Women's Health Sciences Division, part of the National Center for PTSD. I am delighted to be here this afternoon to present on my CDA project, Partner MH, and I thank all of you for taking the time to join me today. So before we get started, I'd like to state that I have no conflict of interest and that the videos presented here are my own. I have a long list of collaborators and colleagues to acknowledge and thank. First, I would like to thank the HSR&D CDA program for supporting me over the past few years in supporting this project. I also would like to acknowledge the Center for Health Information and Communication for the support over the past few years, the George Washington University for collaborating with us on this project. I have a long list of absolutely wonderful CDA mentors and consultants who have been extremely supportive and generous with their wisdom, expertise, and time. I also would like to thank the Query Mentor Program, the research team members who work tirelessly on this project, the interventionists, and our clinical partners locally who have been steadfast in the support of Partner MH. So briefly, I would like to kind of give you an overview of the different things that I would like to cover today. First, I will talk about our process of developing the Partner MH program. Then I'll discuss our pre-implementation evaluation of Partner MH and how we tested Partner MH in a randomized controlled trial. And I'll present some selected results with you. And we'll have some time at the end about possible next steps for this project and for me to take any questions that you have. So briefly, why Partner MH? What is the rationale for this program? Mental health care disparities in the US are well documented, and research projects that have focused specifically on racial and ethnic minoritized veterans have demonstrated that minoritized veterans experience mental health care disparities and discrimination at a higher rate than veterans who are not part of a minoritized group. Specifically, they have shown that minoritized veterans are less likely to receive mental health or substance use treatment compared to white veterans. They're more likely to receive poor quality care, to experience poor relationship with their providers, and to terminate treatment prematurely compared to white veterans. Much of the research on mental health disparities that have been done in the healthcare systems have been in the area of traumatic stress disorder. And more recently, there are studies that have suggested that minoritized veterans who completed PTSD treatment have poorer treatment outcomes compared to their white counterparts, which is quite alarming. Yet, efforts to increase mental health equity have been limited both in the VA healthcare systems and in the general population. There has been reports from different researchers who have suggested that perhaps it might be more effective to develop interventions that target specific communities or minoritized groups instead of having more generalized interventions for everyone. And the rationale for this is that targeted interventions that are tailored really to meet the needs of specific communities might help to access barriers that are unique to these groups or communities. And they might also help foster more person-centered care approach to treatment engagement for minoritized groups. So based on these research findings in the literature, we decided to focus Partner MH on minoritized veterans because they have disproportionate unmet mental health care needs. Mental health care disparities are complex. They arise from the interplay of multiple factors: social, political, cultural, environmental, and interpersonal factors. And there is really a great need to develop interventions to address multiple factors contributing to disparities and at multiple levels, at the personal level, provider level, and healthcare system level. So we have to decide what should be our target for intervention. And to do that, we drew from a body of work that we have developed at the Bush VA that has shown that minoritized veterans experience more barriers to quality mental health care, which leads to disparities in healthcare and health outcomes. We've also shown, and researchers in working in this space have also demonstrated that unproductive patient-provider communication and low patient engagement are key drivers to disparities in mental health and substance use treatment. Substance use disorder treatment for minoritized groups. So thinking about what should be your focus for partner, we developed this program, and partner image stands for proactive recovery-oriented treatment navigation to engage racially diverse veterans in mental health care. Partner image has three specific objectives: to engage veterans in VA mental health services, to support veterans to become more active partners in the care of their providers, and to facilitate their participation in effective communication with providers, specifically to be involved in mental health treatment decision-making. So in our development process, we drew on two evidence-based care models in the social determinants of health framework. The social determinants of health framework basically briefly puts it that they are social factors and the conditions in which we live, grow, play, and work. They all influence our health and our healthcare experiences. And we drew from this framework to help us have a better understanding of the lived experiences of the veterans that we work with and how the social context might affect their healthcare experience. We also understand in partner that for some veterans, it might be challenging for them to prioritize their mental health and to be actively involved in mental health treatment if they worry about where the next meal is coming from, if they worry about or if they experience food insecurity, housing instability, and have their basic social needs unmet. So we really wanted to address barriers that might prevent them from engaging in treatment, which will to help improve their mental health outcomes. We also drew from the patient navigation care model, which is a health intervention in well-established healthcare model that has been implemented in multiple clinical settings and with different types of patient populations. In brief, the goal of the patient navigation care model is to facilitate timely access to health services for patients by eliminating barriers to care, whether at a personal level or more community-based or societal levels barrier. And lastly, we incorporated the peer support services care model, which has been demonstrated to be effective with veterans in the VA system to help engage veterans in mental health and substance use treatment. Peer support services are delivered by peer specialists who are veterans employed by the VA. These are veterans who are in recovery, either from a substance use disorder or mental illness, and they use their lived experiences of navigating mental health treatment and their training to support other veterans who are also in their mental health recovery journey. So in our process developing partner, we wanted to capitalize on what has been done before and that have been shown to work, to be effective. We didn't want to reinvent the wheel. So we partnered with the George Washington University Oncology Program. They have a well-established patient navigation program, and we adapted the model. And in the process of adaptation and development, we also drew from a lot of data and feedback and input from different stakeholders, and that was an iterative process. So one of the things that we did, we conducted rapid ethnography, and I spent hundreds of hours observing peers at work. I observed peers in different settings, in inpatient, outpatient, and residential settings, observing how they engage with veterans to address different mental issues, and learn about what they do really well and where there might be some areas of improvement, learn about how partner MAs will fit in their existing workflow, and what kind of support that they might need to be able to deliver a program like Partner. So this was a year-long process of learning and testing things out and adapting the GWU patient navigation program. So at the end of that process, we ended up with 3 specific products. We developed a training program for the peers to deliver the partner intervention. And the training program included a training manual, a training workbook, and over 40 hours of training that consists of didactics, lectures, hands-on learning exercises, and role-playing with the peers. We also develop a veteran handbook. That's our intervention manual for the veteran to guide the work that they'll be doing with the peers. And we also develop a fidelity assessment measure for the peers. Briefly, this is an overview of the content manual of the training, and the goal of the partner training is to complement the peer training that the peers have already received in the VA. As you can see, it includes topics such as social determinants of health and health equity and how peers can contribute to that, diversity in the veteran population, patient engagement, communication, as well as professional development topics for the peers, including a brief overview of research. This is an example of a peer workbook. We use different modalities to work with the peers. It includes exercises that help them to reflect on their own experiences and how they can use those experiences to work with their veteran client. And this slide is a brief overview of the veteran handbook. It is used as a guide to structure the sessions that the peers have with the veterans. It has 5 different modules. The first module focuses on getting to know the veterans, their story, what matters to them. The peer works with them to set smart goals for treatment. The second module focuses on the wide variety of mental health services that are available to veterans, how they can navigate the system, how to make the most out of the treatment that are available to them. And it covers topics, basic things such as what is the difference between a psychiatrist, a medication provider, and a psychologist or a therapist, and what veterans could expect from visits with these providers and how they could prepare and make the most of them. We also have a module that talks a lot about patient engagement. Very often we talk about our veterans or patients that they need to be engaged in treatment, but we assume that they already know what that means. So in this module, the peers work with the veterans to talk about, well, this is what engagement looks like. These are the different ways you can be engaged in your mental health treatment, and you can set goals to be more engaged with your providers or in your mental health care. And these are the things that you can do outside of your individual visits to really maximize what you can get out of treatment. The next module focuses on planning your mental health visits. It includes a lot of different worksheets and exercises to help veterans think about how they can be prepared for their mental health visits, how they can have questions ready, how they can practice asking questions of their providers, and how they can prioritize their concerns so that they can use their time effectively during the visits. In our prior work, we heard a lot from veterans how frustrated and disappointed they feel. For example, we have veterans who say, well, I left the VA feeling that I accomplished nothing, I didn't get any of my needs met. And the goal of planning the visits is to help them think about, well, what are your goals, what are your concerns, how you can prioritize those, and how you can communicate with your providers to make sure that your needs are met and you feel that you have a productive visit with your care provider. And lastly is shared decision making. So the peers provide a lot of education on what shared decision making is all about and how they can engage in shared decision making with their providers. But they also do a lot of coaching and role playing with the veterans as well. So overall, Partner MH was designed to augment mental health services that veterans are already receiving in the outpatient mental health clinic. It's a manualized intervention. However, it is very flexible. Peers can decide which module to cover based on the veteran's needs and where they are in the process of recovery. They have 6 months to deliver the interventions through individualized sessions. And they have a lot of flexibility in how, in the timing of the scheduling of the sessions. We provided a guideline to the peers to say that the first few months, we encourage you to meet weekly with the veteran and then bi-weekly, then monthly after that. But really, the schedule has to be driven by the veteran's needs and preferences. However, within the first 2 sessions, the peers are required to conduct a social needs assessment where they assess barriers to care that veterans might be experiencing. They also navigate veterans through mental health services and encourage them, if there's a need, to access mental health treatment. And throughout this process, peer support is ongoing. So when we developed Partner, we really thought long and hard about developing a program that could be implemented in the setting. So we incorporated implementation science early on in the development process. We decided to conduct a pre-implementation evaluation to get initial reactions from diverse stakeholders about Partner, how it will meet veterans' needs, how it will be implemented, to understand contextual factors that will affect its implementation down the road, and to identify potential barriers early on so that we can address them still during the development process. For pre-implementation evaluation, we use a mixed methods approach. We use the Consolidated Framework for Implementation Research, the CFR, and use a CFR to guide our data collection and data analysis. For the semi-structured interviews, we provided a brief summary of Partner, his objectives, structure. We also shared a brief video of patient navigation to the study participants and asked them to provide feedback. We asked for their views about what aspects of the program that sound appealing to them, areas of concerns, what would have facilitated adoption of this program, and how it could really meet the needs of veterans and peers in their different settings. We also used the CFR to collect more structured data from the participants. Basically, we have had a survey where we listed all of the different CFR domains and items and how they could apply to Partner, and asked participants if they could rank which domains and CFR items that they think are the most important, that are absolutely essential for us to address to make sure are incorporated in Partner to facilitate adoption, and which CFR items that they thought were not as important for adoption. We also conducted an engagement studio, and I'll say a little bit more about that in a few moments. And we piloted the intervention with a small group of veterans to help us to refine the intervention. If you're interested in learning more about the implementation evaluation process, we published a paper last year, and I do encourage you to check it out. So for evaluation, we collected data from 41 participants from 11 VA facilities in Region 10, and that includes states such as Michigan, Indiana, and Ohio. And we talked to 23 peer specialists, 10 peer supervisors, 7 veterans, and 1 provider. It was really important for us to hear diverse views from peers and veterans and providers of different backgrounds and different clinical settings. So I'll share very briefly with you some of the results from the pre-implementation evaluation. Overall, participants were highly enthusiastic about Partner and deemed it to be acceptable. They thought that Partner was a great idea. There's a need for Partner. It will help improve the mental health services overall, and support veterans to make the most of their mental health treatment. In terms of aspects of the intervention that they found appealing and was useful, they identified navigation services. I thought that there's a great need for that. Participants really liked the idea that this is a peer-led intervention, and they thought that peers will bring a lot of value to the Partner program. And they also really like that we have a strong focus on communication and shared decision-making, which they identified as perhaps the #1 barrier that they see in mental health treatment for minoritized veterans. And on the right here, I have a quote from a participant who shared how he imagines that this process or this program could help other veterans. He shared, "My process of engaging in treatment has been over 2 years now. I probably could have achieved the same thing within 3 months if I had a navigator. I honestly feel like that it just took me that long because I was doing it on my own." And this was a reoccurring theme that we heard a lot from veterans and from peers as well. They feel that having another veteran navigating them through the system helped them understand the process, the composition of their mental health team, the roles of everyone. That could be really helpful. They emphasize how it could be helpful to veterans, but as well to the VA healthcare system in terms of making using resources more effectively. We also heard about a lot of concerns that participants had about partner when we presented the idea to them. So in terms of intervention characteristics that they found least helpful or valuable, so unlike us, they thought that focusing on minoritized veterans was not necessary. It's an aspect of the intervention that they were not too excited about. They had a lot of questions about social determinants of health approach that was not really clear to them. They also had a lot to say about our idea of asking peer supervisors to provide supervision to peer partners, to peers who will be delivering the intervention. And I have a quote from a peer here who talks about his reactions to the fact that partner focuses on minoritized veterans. He shared, I understand that there are fewer minority veterans being treated, and minorities may struggle more to get through the process, but I'm not in agreement with just focusing on minorities. Even though you're a minority, when you're a veteran, you're part of a larger group. Just because I'm Caucasian or anything, my need is so high. And at the point that I identify as a veteran, it doesn't matter. So we had similar concerns from many study participants. They talked about how the veteran identity is the most important identity when it comes to healthcare, and that this sounds like a really great program. It could benefit a lot of veterans regardless of their racial identity. So why limit it to just minoritized veterans? It really forced us to think about how we communicate with different partners and stakeholders, how we presented the data to them, and also that we were coming at this problem of mental health disparities from two different perspectives. A lot of the participants we talked to were more familiar with equality approach to disparities, where we're talking more about health equity. But it also helped us to really emphasize the point that we are starting with minoritized veterans because we need to have an intervention that will address their needs and help reduce disparities. But ultimately, this intervention will help improve mental health services for all veterans because it will improve the quality of services that will be available to all veterans. So it really forces us to think more critically about the language that we use and how we talk about health equity and how we present this intervention to others. The participants also help us identify a number of potential barriers for which we are so thankful because we had the opportunity to think about them early on during our developmental process. For example, they talked a lot about the importance of peer selection and peers training, how partner will fit in the workflow of peers work. We learn a lot about supervisors' time demands and investment in their program and the training that they also need to facilitate their supervisions of peers. We thought when we started this program that we had leadership buy-in, but we got a lot of feedback from participants to say, no, it's not enough. We really need more leadership support for this project. And we had a lot of discussions about implementation climate and the culture of the clinic that is required for the successful implementation of this program. So we have a quote here from a supervisor who shared his experience stating, it was quite a fight when we first started the peer program. Now, fortunately, I have a good set of peers, but that took a long time to get there. And it took some very good peer support specialists that changed some people's minds, and quite honestly, too, for some people to retire. A peer added, the more difficult part is not going to be training the peer. It is going to be more so on creating the environment or finding an existing environment that is conducive, that will be open to the idea of partner. So the participants had a lot of really useful feedback that really forced us to kind of like go back to the drawing board to a certain degree. And we needed help to think about all of the different questions they brought up and the different ideas to help us refine the intervention. So we conducted a community engagement studio. In summer, briefly, we had a one-day meeting, a day-long meeting, where we invited veterans, peers, and providers from both the VA healthcare system, but also from the community to come and help us think through these different issues. We had them divided into small groups, and we gave each small group a specific problem to solve, and then had them come back and share their ideas and potential solutions with the rest of the group. And it was a highly productive process because they really helped us to come up with ideas on how to address many of the identified barriers. And just some key things that we took out of this process. For example, we really went back and think about what leadership buy-in looks like for this specific project. Initially, we were going to rely on volunteer and part-time peers here and there, but we understood that we needed more peers time were embedded in the clinic. So we worked with our local clinical partners, and they hired 2 full-time peers to work in the outpatient clinic, and they dedicated 20% of the peers' time to work on this project. And this was a really great opportunity for us to test partner in more of a real-world setting, where the peers are employed by the clinic, embedded in the clinic, and they have traditional peers responsibilities, but they also delivering the intervention. In addition, we use feedback learned from the engagement studio to improve the training program and the fidelity assessment. So at the end, this is what we have in terms of the core components of partner. We focus on patient engagement, navigation, and communication. We then move on to pilot test partner in a randomized controlled trial. We had 2 specific aims for the trial. First, our goal was to determine feasibility and acceptability of partner. And then we sought to evaluate preliminary effects of partner on patient engagement, patient activation, shared decision-making, and related health outcomes. We sought to recruit 50 veterans and to randomize 30 of those veterans to the active partner arm and 20 to a waitlist control. Participants in the waitlist control were eligible to receive the partner intervention at the end of the 6 months wait period. Our eligibility criteria were very limited. We required that participants identify as someone of a minoritized, from a minoritized group, and that they had initiated treatment in the mental health clinic within 6 months of enrollment in the partner program. We collected data at baseline, 3 months, 6 months, which was our endpoint, and 9 months for us to assess sustained effect of the intervention. Again, as a reminder, the peers had 6 months to cover the intervention materials. We did not have a predetermined number of sessions for them to reach. When we started partner, when we developed the intervention, it was designed to be an in-person intervention. But because we started the RCT in August 2020, right in the middle of the pandemic, we had to change our modality and bring the partner criteria out. This is, on this slide, you'll see our interventionists. We have 2 wonderful peer specialists who deliver the program. And I also have Dr. Patterson, who is the peer program coordinator and supervisor at our facility. He has been involved from the beginning in this project and actively collaborated with us through every step of the way. He provided supervision to the peers as part of their regular peer work in the clinic, and that also includes supervision of partner cases. I also met with the peers on a weekly basis for group supervision and met with them for individual supervision on an as-needed basis. So they had a lot of support from the 2 of us, from Dr. Patterson and I, throughout the course of the study. So is partner feasible? Our goal was to recruit 50 study participants. And despite COVID-19, we successfully recruited enrolled and randomized 50 participants from August 17, 2020 to April 1st, 2021. And we completed our last follow-up assessment in May 2022. Our recruitment rate was 68%. Because of COVID, a lot of the strategies that we typically use for recruitment, we were not able to use those. But once we were able to recruit participants, we successfully enrolled them in the study. So our enrollment rate was 91%. On average, the range of sessions completed was 0 to 17. 38% of study participants completed 3 sessions or less, 41% completed 4 to 9 sessions, and 21% completed 10 or more sessions. So there's quite a bit of a range there. Overall retention in the study was 72%. Retention in the active arm was much lower, it was 60%. 4 participants withdrew from the study and 10 were lost to follow-up, including 1 participant that were just not able to reach after that participant completed the baseline assessment. We experienced a lot of challenges with retention. Study participants were very complex. They had a lot of health and social needs. We had a number of participants who were hospitalized during the course of the study for medical reasons. We have a number of participants who were in and out of residential treatment for substance use disorders. We had participants who were incarcerated, and we had participants who just had a lot going on, and participating in yet another project or program was just too overwhelming for them. I don't think I need to explain how COVID-19 impacted the project, but one of the outcomes of COVID-19 was our transition to telehealth modality. While that worked for some veterans, for many of our study participants, it was really a downside. They prefer to meet one-on-one in person with the peer, and providing the services via the phone or via VC telehealth modality was a challenge for many of them, and that affected their participation or engagement in the program. I will say of all of the different barriers or factors that impacted retention, the peer schedule was probably the number one, and that's based on the feedback we received from study participants. The peers had 20% of their FT allocated to delivering the intervention. However, they had set hours in the day on when they can meet with partner clients, and that just was not conducive to meeting many of our study participants who needed a lot more flexibility. And that is one lesson that we learned from doing this trial. We also learned that there's not a one-size-fits-all, that it took participants a varied length of time to cover the intervention materials and also to engage participants in mental health services and in the program. We also are very excited that the peers remain highly engaged throughout the course of the study, despite many study setbacks as well as personal challenges that both of them experienced over the past 2 years. So briefly, this is an overview of our study participant characteristics at baseline. Randomization led to very similar groups for both the active partner MH arm, intervention arm, and the waitlist control, except for gender. We had more female participants in the waitlist control group. Overall, 62% of our study participants are male. We had a really nice even distribution across age groups. We had an educated participant sample. 48% had some college education, and 32% had at least 4 years of college education. More, 70% were Black, 88% were not Hispanic. We had a broad range of diagnosis. 70% had mood disorders, 45% had a diagnosis of PTSD, and 30% had a diagnosis of substance use disorder. And at baseline, 34% of our participants reported suicidal ideation. So is partner acceptable? We had high rates of satisfaction reported from study participants. 89% reported satisfaction with the partner program. 82% of study participants agreed that my peer helped me make progress on my mental health treatment and goals. 89% reported that the peer support calls helped me feel more confident in managing my mental health treatment and reaching my goals. 89% also agreed with the statement, I will be more satisfied with my healthcare if a peer support service like this was available to patients. And here I share with you veterans' comments in their own words and how they talk about their experience with partner. So one female participant shared, around the time I started navigating through the mental health system at the VA, I was so angry. It was at the point where I wanted to hurt other people. So in the last almost year, I've learned so much. I feel so much better. And I give a lot of credit to John, the peer, because he was that lifeline I needed in that moment. Another participant shared, I think more veterans need to do the partner program because I think it will help them. It will help them get the help they needed, give them a better perspective on their mental health. James helped me open my eyes to different ways to do things. So as part of our evaluation, we also assess participant satisfactions with the care that they receive in the clinic. Overall, participants in the active intervention arm had increased scores in satisfactions with the care they received from the clinic, whereas those in the reduced control group, their satisfaction scores decreased at the end of the study. Similarly, whether they will recommend or likely they will recommend a mental health clinic, we see improvements for participants in the mental health group, but no change for those in the waitlist group. So participating in the partner program seemed to positively impact veteran satisfactions with the care that they receive from the mental health clinic at the VA. So moving on to talk about our second aim, the preliminary effects of partner image. These are the different outcome measures that we use. We use the Alterum Consumer Engagement Scale to look at patient engagement. We use the patient activation measure in mental health to assess patient activation, and the SDM-Q9 to assess shared decision making. We also look at communication self-efficacy or alliance with mental health provider, depression, self-reported mental health, and physical health. At baseline, there were no significant differences between participating in the active arm and the waitlist control group. We also assess participants' barriers to care and unmet social needs. On average, participants reported 3.4 barriers to care or unmet social needs, and the range was from 0 to 9. As you can see on the slides, most participants reported experiences of social isolation and loneliness. At first, we attributed this to during the study, during a pandemic, and with COVID restrictions, a lot of people were experiencing isolation and loneliness. But it was such a dominant theme in conversations between peers and veterans that it really helped us realize that it went beyond COVID-19. This was an unmet needs for many of the veterans in the program. About 14% of our veterans struggle with food insecurity. 28% had housing instability and a number of other unmet social needs. And this was an opportunity for the peers to address their needs before they reach a crisis point and to direct them to available VA resources. We also assess participants' responses to doing the unmet social needs screening. This is Oflex's first experience doing the screening, and as far as I know, there aren't a lot of VA programs that are systematically assess social needs in the VA, although I think we are going in that direction. So this was an opportunity for us to get feedback from veterans. And I'll share the first one briefly with you. So veterans share, well, at first, the social needs screening was just weird. Because different parts of my mental health recovery where I needed to speak out about those things, unmet needs, and I did it. Right now, when I first joined the program, financially with my food and housing, I'm completely stable. So the screening didn't feel applicable. But I know through my ups and downs in the mental health clinic, they've been very relevant in the past where I've been almost homeless. But I think it should be asked to every veteran every time. It just didn't feel relevant to me at the time. Doesn't mean that it can be relevant in the future. And a female veteran shared, well, the peer told me he could hook me up with resources if I needed housing, food, or anything. So we had that personal connection. But he wasn't just bringing words to the table. There was some action he was willing to take if I needed those additional things. I think every organization at this point is so overwhelmed, including the VA. We've got to make sure that our veterans are taken care of at all costs. And I think this Partner MH is a good vehicle to get there. So there was a lot of positive feedback. Our veterans appreciated being asked if they have barriers to care, to engagement in treatment, and unmet social needs that the VA could help support. So moving on to talk about the effects of Partner MH. Just a reminder, our goal was primarily to assess visibility and accessibility, acceptability. And we're hoping to see changes in scores pointing to the right direction to indicate potential effectiveness of partner down the road. And the results show that we had improvements in scores for participants in the active arm on most of the measures. However, they were not significant. Yet we had statistically significant improvements for participants in the active intervention arm on depression scores and self-reported mental health function. Although we did not expect it, it was really nice to see that Partner MH had a significant improvement on veterans' mental health outcomes. We also assessed the long-term effects of Partner, looking at improvement in scores over time. The results were not significant. We were not powered to determine any significance at this level, but we were able to see sustained effects of the intervention on all of the measures at 9 months, which is highly encouraging. And next, I just would like to share with you some brief excerpts from participants' interviews describing the experience with Partner and the impacts that it has had on them. When participants shared, you gotta be engaged. I would say that's probably the biggest thing I've learned. Before I was doing nothing. I didn't make any kind of effort at all. After speaking with John, just knowing it's my mental health and I'm responsible for it as well. Here's another quote. I was kind of just going with the flow. I didn't really have any clear-cut ideas about what I should be doing or anything to work towards as far as my mental health is concerned. So Partner did help me organize my thoughts and my concerns and get a game plan. I think I'm a little more proactive about shared decision making. So I guess I'm a little bit more empowered to really engage in that process. And here's one last clip. We set up a few SMART goals. One was for regular physical activities. Another was for talking with my provider about certain things I wanted to address and never addressed. And the other was continuing recovery plan. So we set them all up, we wrote them down, monitored progress, and follow up with them. And that's where I noticed that writing things down to improve things overall. I'm going back to school again in June, and I'm doing SMART goals again because I got back into it because of the Partner workbook. So they were able to utilize the workbook and the worksheets we had beyond the scope of the program to apply in other conditions in their lives, which was really nice to see. So key points, takeaway points, the results of the randomized control trials show that Partner is feasible and acceptable. The preliminary effects show positive trends in the right direction. Again, the effects of the intervention are sustained over time. But we also learned from doing this trial that Partner is a complex intervention that requires training and support, a lot of support for the peers, and that there are some modifications that we need to make sure that the interventions meet the needs of the veterans and the peers in the program. So what is next? Where do we go from here? We are still in the process of finalizing our data analysis. So we are going through the qualitative interviews at this time. We also plan to refine the intervention and hope to identify sites for future testing of a larger and powered trial to demonstrate the effectiveness of Partner MH. And also thinking about how we could potentially adapt Partner MH to a more specific subset of veterans, for example, veterans struggling with PTSD in specialized PTSD treatment programs. And we learned a lot working with participants in the study, and many of them had a PTSD diagnosis. I am eager to hear from all of you about any thoughts, suggestions, or comments that you may have about where we might go next, or overall comments about the Partner MH program. I would like to thank you all for your attention and for joining us today. So Robert, I'm going to turn it back to you.
Thank you, Dr. Eliacin. We do have one question queued up, so we can jump right in. But first, let me just say, attendees, if you have questions, please send them to the Q&A, and I will read them to Dr. Eliacin. If you don't see the Q&A, click on the ellipsis button, the 3 dots in the lower right-hand corner, and you'll see Q&A there, and you can turn it on. Please don't use the chat. It's a little bit more difficult to navigate. So jumping right in, this is a little bit of a long one, but basically it's about funding. This person says, thanks for such a detailed and insightful presentation. Could you talk more about how you were able to secure funding for 2 peers? Was this funding through your CDA or through operational partners? What tips do you have for others who are looking to secure funding for a similar program in mental health or other settings?
Thank you, Rob, and thank you to the participant for this question. I had some funding through my CDA to support part of one peer. So I was able to cover only 20% of one peer, but I knew that was not sufficient, especially after we completed the pre-implementation evaluation. So we work with our psychiatry services at our facility and our clinical partners who were really supportive of this program, and they hired the 2 peers, and they basically donated their time to this project. So they were very generous. With the CDA budget, as you may know, it's not a big budget, so we have limited funds. So I'm very thankful that our clinical partners were able to cover the bill. So they hired 2 full-time peers, and they basically said, well, you can have 20% of each of the time, which is a lot more than what we had initially planned. And it worked out really great because we needed more than 1 person to do this work. So I would suggest work with your local partners and think about how a similar type of situation could benefit both parties. And for our clinical partners, it worked out really well for them because they never had peers before in the clinic. It was the first time hiring the peers. And what we offered was a lot of training. So we selected and helped them hire the peers, and we provided an extensive amount of training and support to those peers. And the peers are still working in the clinic. So they have 2 peers who are now highly trained and who have deep understanding and knowledge of partner. And if the clinic chooses to do, they can continue deliver partner or aspects of the intervention. And the peers are still doing that. They are incorporating many aspects of the intervention in their regular routine interactions with veterans. So it benefits the peers and it benefits the clinic as well.
Thank you. The only other questions that we have, one person is asking for the slides, and I just sent the slide link out again through the chat, but there was also a link in the email that you received approximately 4 hours ago, so you should be able to get to those slides even after the webinar. Another person makes a comment that this was an excellent presentation. Oh, and here's a question. Are the training materials and or peer/participant materials available to other researchers?
That's a great question. Not at this time, because we are still in the process of fine-tuning the training materials and the intervention manual. But it is our intention to make all of the materials that we are using accessible to researchers and to other peer programs. The VA National Peer Program is one of our partners, and we'll definitely make that accessible to them, and they can help disseminate it to other clinicians or other researchers who might be interested in partner. But at this time, we are still in the process of refining and testing the program, so it's not widely available yet. But if you have specific questions about peer training or any aspect of the partner program, I'm happy to talk with you privately after this presentation.
And the best way to contact you would be via the email that you have on this slide right here?
Yes. Yes, that's correct.
Thank you. One just came in. I will be doing some similar community partnership work to build an intervention through my CDA to address food insecurity. Do you have some material on how you ran your workshop?
Yes. I will be happy to share with you on how we did the community engagement process, how we were able to recruit participants both within the VA and also outside of the VA, and how we structured the engagement studio to get feedback from veterans. So I'm happy to share lessons learned with you as well.
Well, at this time, we don't have any more questions queued up. That person that you just answered to writes in, thank you. But we don't have any other questions queued up. It's possible that people will send some in momentarily. Maybe people are still crafting their questions or they haven't figured out what the questions are yet. But I think usually now is a good time for you to make closing comments while we see if any more questions come in. Do you have any closing comments, Dr. Eliacin?
Sure. I'm really excited about Partner Image, and I look forward to continue this work. And I'm look forward to hear from others who have had experience with conducting this type of programs in the VA. If they are willing to share their wisdom or we have suggestions on next steps that we might be able to take to test the effectiveness of the intervention, or might be interested in partnering with us, because we are also looking at sites that might be conducive to implementing partners. So please do reach out, and I appreciate your interest in this project, and thank you all for the work that you do with veterans and for attending this presentation.
Well, thank you for your work for the VA, for veterans, and thank you for preparing and presenting today. Attendees, when I close the webinar in a moment, a separate web page will pop up with a few survey questions. Please take a few moments and provide answers to those questions. We do review them and count on them to try to improve on our already excellent product. Once again, thank you for your time today, Dr. Eliacin, and thanks everybody for attending.
Thank you.